Hi, this is David King-Lassman. Welcome to another episode of ExploreXR. And today I am delighted to be joined by Dr. James Kinross from Imperial College London. Hi, James. Welcome.
Good evening. Good morning. Nice to be...
Yeah, that good old 8-hour time difference. Morning for me, evening for you. So let's kick off. You work at Imperial. Let's have a little bit about you. What do you do at the hospital, James?
So, yeah, interesting question. So I'm a clinical scientist. I guess in American money, I'd be an assistant professor in surgery. I'm a colorectal surgeon. My day-to-day is treating bowel cancer. So I'm a robotic colorectal surgeon, and I work in the National Health Service part of my time. And the other half of my time, I have a research group here at Imperial College London. And we, amongst many other things, are looking at the impact of what we call digital surgery on clinical outcomes. So how we're using data, computational science to improve the precision of the work that we do and make surgical care safer.
So that right from the get-go there's an interesting mix here of medical talent and technology, right? Which we don't think about so much when we think about doctors.
Well, I don't know if talent's the right word. Certainly resilience. I think anyone, if you speak to any surgery, you've just got to be stupid enough to keep going. So yeah, I think the NHS in many ways has been quite forward-looking in this regard. They understand when you have a lean, well, at least financially lean service, that the only way that you can really improve it is to innovate. Innovate is absolutely in our DNA. And it's quite good at supporting clinicians coming through who have that urge to innovate. And we have a number of different academic programs that allow training doctors to go in and do that. So I did a PhD quite early on in my career. My PhD was in computational science. It was actually in the biological sciences, not in computational imaging, which we're going to talk about in a second. But yeah, so actually I've come through a relatively straightforward academic pathway, which has led me to a point where I have my own research group working part-time in clinical practice.
So you probably spent the best part of your formative years in education, right? Because it takes years to become a doctor and then the PhD on top of that.
Yeah, I have a grey hair for a reason. Yeah, I do. But yeah, I mean, I qualified as, I mean, to put it into perspective, our training in the UK is a little longer than it is in the US, and we have more of a generalist training. So, I mean, I qualified out of med school in 2001. I became an attending 2015, and yeah, I've been sort of in practice now for around 7 years.
So can we talk a little bit about Imperial? So Imperial is a big, major institution right in the heart of London.
Yeah.
What makes this hospital special in the landscape of the NHS trusts? Yeah,
so we are a science and technology university. So it's a bit like Caltech or MIT. You know, we specialize very much in physical sciences, life sciences, medicine, engineering. We don't have a lot of the humanities in the organization, which is not necessarily a good thing, but anyway, that's where it is. And it's unique because we are a hospital trust that is run by a university. So we're an NHS hospital, which is in theory managed by an academic organization. And in fact, we're something called an academic health science center. So we are funded, structured, and run with the aim of getting technology and innovation from benchtop to bedside as quickly and as efficiently as is possible. At least that is the theory. Yeah. In practice, it's not quite that straightforward. So we're very much a science and technology organization, and it's a tremendous luxury for me. I get to spend my day talking to computer scientists and to engineers and to biologists who are just really, really smart people. And we spend our time thinking about how we can take what they do and bring it into the clinic.
Right. And this is a fascinating time for the United Kingdom and the NHS in particular. You know, it's well documented that there have been some real struggles and challenges that the NHS has faced. How has that impacted the work that you're doing, particularly when we think about sources of funding to drive that innovation that you described earlier?
Yeah, I don't think the NHS is unique in facing challenges at the moment. The US healthcare system has got its own
Sure.
well-documented problems. Yeah, I mean, we've got problems because of our own self-inflicted kind of Brexit episode, but also the pandemic and the downturn. So we've got very significant workforce problems at the moment, and a lot of our public services across the board are underfunded and pretty burnt out. So at the moment, things are really, really challenging. Actually, as bad as I've ever remembered them. In fact, I think you've got to go back to the mid '90s, early '90s before it's to find someone that remembers it being quite as bad as it is now. So I think you can either respond to that challenge in one of two ways. You either sort of give into it a little bit and you collapse under it, or you make a decision to kind of innovate and fight your way out of it. And in our organization, that's what we're trying to do. I made that sound a little bit more, I don't know, I've perhaps oversimplified it. We've got huge challenges in our organization. There's absolutely no doubt about it. But yeah, our job is to find technology solutions and to find new ways of working that solve some of our absolutely most fundamental problems. Yeah, and at the moment, right at its heart is our workforce. Our workforce really is exhausted.
So can we talk about how technology is addressing those particular challenges? Are you seeing innovation around that, about retaining staff or upskilling staff, fast tracking education so we can get people on the front lines? How is technology playing a role in that from your perspective?
Well, that's a brilliant question. So yeah, we are seeing quite significant changes, actually. So it became really apparent during the pandemic that we were going to have, very early on in the pandemic, I mean, literally within the first few weeks that London was hit, that this was going to have a very significant impact on our staff retention and our staff training. So we saw quite quickly educators turning to technology to help solve those problems. So, for example, in the earliest phases, it was very much around digital proctoring or remote proctoring for surgery, for example, or using kind of video-based education and training tools. I think we were in a slightly fortunate situation where we had been developing some of these sorts of methodologies for some time before the pandemic hit. So we were quite quickly able to translate them. But I think what we have also seen is educators looking to emerging technologies to try and fill that gap, and that's where we've seen things like VR, XR, MR, whatever you want to call it, come to the fore, and to see them being readily adopted. I think there was a very quick drive to see where they had capacity and where they had a unique function. So there was a lot of rapid adoption, and then there was perhaps a slight realignment as they worked out really where the wins were, and some realignment. And we're now seeing a more structured and, I suppose, standardized way of them being applied.
Right. And during the pandemic, you actually brought the HoloLens into the hospital, and you used it to good effect. Can you talk a little bit about that?
Sure. So I was in a luxurious position during the pandemic because I'm a surgeon, and in a pandemic, there's not a lot of need for surgeons. Actually, ironically, there was a lot of need for surgery, and we should have never stopped operating, but that's a different story. And we'll come on to talk about the role of mixed reality technology in doing that in a second. But we found ourselves, with a bit of time to kill, and so we thought we better apply ourselves quite quickly. So we had a chat with Microsoft early on, and they said, "Hey, would you be interested in doing something with the HoloLens?" And we sort of were unsure, frankly, whether or not it really had a role, because we had really significant problems. But we put together a core group of engineers, clinicians, and data scientists, and we had a really small kind of focus group, and we thought that we might be able to apply it in some specific use cases. And we were able to sort of go to clinicians and have a very iterative process and say, "Hey, look, we think we've got this tool. Do you think it would be useful? Yes or no?" And if they said no, we just moved on. We weren't there to try and persuade them that it was useful. And what was interesting about that was that all our early use cases that we thought it was going to be useful turned out that they just didn't have the bandwidth to do it. So, for example, back in the really bad days of the pandemic, we had nurses working in isolation, managing really, really sick patients who were ventilated, and they didn't have any experience in working or managing those ventilators. So we wanted to give them remote support, and then to give them real-time training on the job and using the HoloLens to do it. And it just wasn't the right environment. And actually, in the end, it was a geriatrician who's someone who works with older people, who said, "Look, I really need this. I'd be prepared to work with it." So we worked really very iteratively, and the basic idea was that we were going to create a form of digital PPE. So what we wanted to do was, instead of sending 4 or 5 clinicians into a high risk environment, we would send one in using basically a simple HoloLens and a remote assist. And we were very quickly able to get that through the kind of hospital data protection and ethical processes and get it kind of fast tracked in. And we had to do some fairly quick and dirty safety work to make sure that these headsets could be adequately cleaned and decontaminated, and that they were safe to use. And then we in a very sort of agile way introduced it into clinical practice. So we started with clinical ward rounds with doctors wearing the headset, reporting. So the consultant or the attending would go into the clinical environment wearing the headset, and the junior team would be outside. And we measured the performance of the HoloLens, we measured the quality of those interactions, we measured the clinical outcomes, both in terms of doctor sickness, but also in terms of patient outcomes, and we measured PPE consumption. And within a few weeks, we kind of had, quite a startling impact. So we found like an 800% reduction in PPE usage, which was really significant at the time, as we didn't have any, and there was a national shortage in the UK. We found that the efficiency of the ward rounds grew by about 30%. We found that the quality of communication improved dramatically, because when you're trying to communicate in a PPE kind of environment, it's very difficult to hear what's being said. But if you've got a nice HoloLens on and you can see everything as a junior doctor, you can hear everything, everything gets better. And we also found that COVID rates in our staff dropped dramatically. So we knew we were winning when people were knocking on our door going, hey, where's a HoloLens? I need a HoloLens, right? So these were Luddites going, I need this technology. And suddenly we thought, maybe that's interesting. And then quite quickly, we realized that we weren't educating our undergraduate medical students. All education had stopped. We weren't training any of our postgrads. And we thought, well, how do we leverage this to help bring medical students into the kind of COVID environment to learn? So we then started doing real-time kind of ward rounds, so doing kind of clinical sessions for medical students, and then we also started going into kind of postgrad environments, so the operating room or resus bays, etc., to try and teach our students. And ultimately we formed collaborative links with various US organizations, and we started doing kind of international grand rounds, so holographic grand rounds, and it all sort of escalated from there.
Yeah, I mean, it's really interesting actually, because as you know, we're deeply passionate about mixed reality, in particular extended reality. Yes, but mixed reality is where GigXR plays. Yeah. Clearly, you were able to use the benefits of mixed reality in a way that you couldn't achieve with other types of medium, like virtual reality. That must have been pretty exciting and impactful.
Yeah, it was really cool. It was really cool. It was really cool to watch. When it's one of those things where we'd worked with mixed reality for some years. So we've been developing those applications in the surgical, field. So we have known, like many others for many years, that if you can visualize complex anatomy, it really makes a difference, if you're trying to educate and teach, but also if you're trying to operate more safely. So we've been working on that for about 5 or 6 years before COVID. So, when you kind of really know something's really important, impactful, and you've been trying to communicate this to people for years, and suddenly people get it, it's exciting just to watch it, watch it take off. And I think for us, mixed reality was really, really important because for a number of really critical reasons. Number one, because when you're dealing with patients, when you're interacting with a patient, the clinician is very much in the loop. So the patient can see the clinician can have eye contact with the patient and hold the hand, and the patients really responded well to it. So that was number one. Number two, context is absolutely everything when you're teaching clinical practice. So you can't, sometimes being in a completely immersive virtual environment, it's not helpful, actually. What you really want to do is you want to be in the shop floor, seeing that information or seeing that learning, where it actually has to be delivered. And we found it very helpful when you were trying to learn with our American colleagues, who were, in a completely different health system, and to see their experience and to see the tools that we were developing within their environment. So clinical context is absolutely everything. But also mixed reality, there's something in the way that the brain processes that holographic component, and something in the learning methodology that is just different. And people are able to grasp ideas, grasp quite abstract concepts really efficiently, and that's really exciting to see.
Yeah. What I find fascinating about the experience you described during the pandemic is that I think we know that in healthcare, there's usually a very long process before something is implemented. There's research, there's data, there's compliance, there's privacy. And sometimes it can be wildly frustrating for the innovators because it takes so long. You didn't have that luxury. Do you think that some of the lessons learned during that pandemic will seep into the way we do things in the future, so that we can get technologies out there and put to work more efficiently?
Never waste a good crisis, right?
Yeah.
So the answer to that question, I think, probably comes in two parts. I think the positive bit is that there is now a much deeper understanding that the way that we were working was very inefficient, and the technologies out there that currently exist should allow us to do our jobs as clinicians much more effectively than we can today, right? And the simplest, impact has been this. It's been video conferencing. It's been, it's been the kind of low-hanging fruit technologies, and I think that is obviously going to change, and we're just not going back. I think part of my frustration has been a lot of the barriers to innovation are not actually technological or technical. They are clinical governance, ethical. They are these sorts of processes which have an important role, right? They're there to keep the patient safe, but sometimes the bureaucracy is just so infuriating. And we saw all of those bureaucratic barriers come down, and we thought, oh, okay, brilliant, we're never going to go back there. And slowly they've all crept back up again, right? And I think I worry a little bit that they're not going to perhaps go back down where we really need them to be. What I do think is going to happen, though, is that I think what we are starting to do is to design clinical processes around the technology from the ground up. They're going to get the best out of those technologies in a way that they were meant to be. So rather than layering them on top of what we were doing before, what we're actually going to do is design clinical pathways from the ground up that say, okay, this is, how do we completely rethink this pathway, and that is best for the patient, best for the clinician, best for the healthcare provider, and how do we use technologies to do that more effectively? And I think that's going to ultimately be a bit of a step change.
Cool. So let's stick with mixed reality. Where do you see it driving the most impact in your hospital over the course of the next 12, 24 months or so?
So I think that's a really interesting question. So I think in two domains, I think education and training, we've got a really big problem, right? We've got young trainees who've lost up to 2 years of their clinical training, and we've got a massive deficit. We've got to speed up the process of training to get our workforce back to where it needs to be, and we've got to improve the quality of that training all of the time. And I think mixed reality, to me, it's an absolute no-brainer. It's not a panacea. It doesn't solve all of your problems. It's not going to be the answer for every training problem that you've got, but it's now, in my opinion, an essential tool that you need to have in your armory to deliver particular types of training and education. I also think it's going to have a major impact in direct clinical care. So we are particularly in my group and with our kind of work that we do, particularly interested in some, avenues where we think the initial gains are going to be. So that's going to be in interventional radiology and probably in surgical interventions, or at least technical specialities or practical specialities where you're performing interventions of some form, because we think that's where the greatest win is for the kind of holographic component of mixed reality. And what we're trying to do at the moment is solve some of the fundamental problems for how you introduce those technologies at scale, and how you do that safely with an evidence base that clinicians and patients can trust.
And how long do you think that last bit takes when you get to get the evidence, to get the data to support the thesis?
It depends how much money you've got. So it depends how much money you've got, and so I think again that the answer to that question comes in two parts. I think there is doing the science, and then there's changing the culture, right? So I think some specialties, some clinical areas are going to be slower than others, and some are very fast moving. And what we're trying to do is to pick the ones that we think where we're going to have a really big impact. So for us, for example, neurovascular interventional radiology, we think there's a quick win because there are really big problems that we can solve quite quickly. Like, how do you get a wire up into the brain as fast as you possibly can to pull out a clot? Well, at the moment, you've got to use 2D fluoroscopy in 2 dimensions, and you just can't visualize and see what you need to see. And it's very difficult, unless you're incredibly skilled and well-trained, to know how to rotate and twist and put torque on the wire to get it to where you need to be. Right? We can solve that problem quickly, and the gains are really significant, and we can demonstrate the evidence for that quite quickly, and that will change practice. Whereas if you're trying to persuade perhaps a policymaker or someone at a institutional level that actually you need strategic investment in these technologies for education and for training, I think that's going to take a bit more time. And I think part of the reason for that is that the technology has gone a little bit before the pedagogy and the educational theory that's going to underpin it. So I think educators are very excited about the technology, but they need to know that if they're going to make strategic investments in headsets or software or, you know, cloud-based architecture, that actually their students, their people are going to have the real kind of benefit from. So for me, it's like this is absolutely coming, right? It's a no-brainer. It's going to get there. The question is just how quickly.
Yeah, and I know that we've talked about this many times in the conversations that we've had about, you know, getting that data. I know that you've undertaken some research already. You've actually done some research with one of our products with HoloPatient, and it was a fairly small study, but the results were encouraging, right?
Well, yeah, you know, accepting all the bias on this call, they were encouraging. And so just to give your listeners a little bit of an understanding of what we did, we are interested in how you use holographic patients for assessment. So can you use them to test the knowledge or technical skill of a medical student getting through their exams into clinical practice? So we have objective, you know, clinical assessments that we do. These exams are called OSCEs, and we trialed your holographic module for the COVID patient to see whether or not it was a robust way of measuring student performance. And the answer is, yeah, it really is robust. And that's really great news if you're trying to run exams for thousands of medical students in an organization where patients are really difficult to get hold of. But it's also very, very helpful for assessing particular aspects of clinical decision making. So particularly what we call these kind of gray areas of decision making, because medical school is when you're taught medical theory, sometimes it's black and white. There is a right and there is a wrong, but in the real world, that's just not how it is. There's lots of gray areas. Sometimes you're not quite sure what to do. So we found it particularly useful for that. And we've just completed a second trial, which we're just submitting the data on, looking at using mixed reality for teaching residents how to perform clinical tasks in a resuscitation environment. And what we find is that when you use that technology, I'll get straight to the punchline on this, you know, it reduces anxiety, it improves the likelihood that these students are going to be able to complete that task successfully, and it reduces the error rate, but it takes a little bit longer. So, you know, we find that we find consistently there are benefits, and we find that the barriers to introducing that technology are not quite as tough as we think they are. Actually, students will quite quickly adapt to the mixed reality environment. They don't need a lot of education training to be competent to use it, and actually they quite like it.
Yeah, that's great to hear. Look, technology moving at lightning pace here, and you know we're looking at what's happening around AI and ChatGPT and all of that good stuff. What do you think is missing from the mixed reality or the technology landscape that is going to be impacted by some of the incredible innovation, the speed of that innovation that we're seeing happening today?
So I think with all technology and with all kind of I suppose what I would call kind of high risk innovations like these, what's missing is the human component, right? So the challenge to translating these technologies into clinical practice are not technical. They are all behavioral, and they're all about human factors, and they're about evidence and leadership and in that cultural change that allows them to move forward. So I think what we need, I think, in mixed reality specifically, is some really high impact clinical trials that definitively prove to the doubters that actually this technology really is genuinely transformative. And I think what we've seen is small studies, small pilots, and I'm guilty of doing the same thing on that, but that's just how all technologies start. And I think what we really want now is large scale, well-funded studies powered to a clinical endpoint that definitively demonstrate that this changes the game. And that means multinational, probably, or at least certainly multi-center collaborative pieces of work, really done at scale, that don't just, I should say, prove the clinical point, but actually prove the economic value of these things and the value on process and efficiencies for organizations and healthcare providers and other stakeholders in these technologies. And I think we need a couple of really killer studies that are going to transform practice. Yeah. I think they're going to come, but I think that's what we need.
Yeah, the sooner the better, as far as we're all concerned, I think. Yeah. And I'm also fascinated by you introducing this sort of human element. I think that's one of the things that mixed reality does very well, in that you're connected to the people around you. We've been working on a BLS app that isn't designed to teach you how to do CPR. The assumption is you know how to do CPR, but how do you communicate in that environment? How do you take student doctors and teach them how to do a procedure, but then give them the kind of clinical confidence not to freeze, not to be the deer in the headlight when they're faced with that situation. That I think that's one of the great benefits of this medium.
I 100% agree with you. And, to give you another analogy, so I'm a surgeon. My performance as a surgeon is completely dependent on the team performance around me, right? So I can only be as good as my team is, and if my scrub team and my anesthetic team and my pre-op team aren't up to the job, we will not perform well, and our patient will not have a great outcome. So for us, we are excited about the role of mixed reality in team training and trying to get teams to function well together, and to do that in a kind of safe and reliable space. So yeah, we are in complete agreement with you there.
Yeah. So I think we've covered quite a lot of bases. I think what's clear is that we're both big enthusiasts. I wasn't aware of quite how enthusiastic you were about this kind of technology.
No. I'm. To me, it's like being. Like when you put on a headset, whatever company you use, right, for the first time, a bit like being shown an X-ray for the first time. It's like, oh my God, this is a completely different way of seeing the world. And once you've seen it, you can't unsee it. And so yeah, I'm 100% an evangelist, but at the same time, I am a realist, right? Which is that if you, I suppose one of the most challenging, but also the most exciting problems we have with this technology is that it raises fundamental questions about how we do our work and how we integrate these technologies into clinical practice. And what I do think we need to do here is to think quite carefully, because the cart cannot go before the horse for a number of different reasons. I mean, first of all, patients will come to harm, but secondly, because companies will fail and people will lose money, and also the technology will just be pushed back, right? We need it now, but we've got to do it in a process. So we published a Delphi exercise quite recently in Nature Digital Medicine. I can send you the link for your listeners if you like, where we kind of mapped out the major barriers and opportunities that we have for integrating these sorts of digital technologies into clinical practice. And we're really lacking some quite fundamentals. We're lacking fundamentals in terms of data standards, data ontology. We're lacking, a common language that we can all speak, and common definitions around even some of the technology. We can't even decide if it's XR or MR, and people use these terms interchangeably, and we really need those things. And we need to have organizations that are going to be I suppose creating quality standards for the work that we do, so that, the technology is great, but the quality of the trials and the quality of the studies we've got to do has got to be excellent too. Otherwise, we're just not going to bring people with us. So we're increasingly interested in that kind of human element, the governance, the ethical element, that, when you're wearing a headset and you're in a clinical environment, you're recording everyone and everything around you. And we don't know what the implication of that really is at the moment. And though there might be some really positive things to come out of this, there will absolutely be some unintended consequences of this technology. We need to be sure that we're prepared to manage that, I think.
Yeah. And I think one of the challenges that the industry as a whole has to face up to is that the young people that are coming into the system, the undergraduates, the F1s, the F2s, they have an expectation that technology is going to play a big role, not just in the way that they train, but in the way that they operate. I've said it before, today's kids are born with mobile devices in their back pocket. They know how to navigate these things very well. We need to really consider that, don't we, as well, when we think about how we educate?
So I think that's an interesting question. So, I think our kids, and I call them kids not disrespectfully, just that they are literally 18 or 19 when they come to school, so they come as undergraduates in the UK compared to the US, where it's a postgraduate thing. But they don't come to a world top 10 university expecting anything other than cutting edge methods of education, and they're very, very demanding now in a way that they weren't several years ago. But at the same time, what we really want is to democratize these technologies so that even if wherever you're being educated and however you're being educated, you have access to these things. So a core part of our mission is how we ensure that those aren't fortunate enough to be learning their skill set in a major London teaching hospital also get access to those same learning and training opportunities, but also how our people can learn from those clinicians who are practicing in austere environments or environments where perhaps they're performing work that our students simply can't access to. So, for example, in our hospital, we don't have a pediatric cardiac group. So actually, we want them to be able to learn from other organizations. I want to know what you're doing in Los Angeles. I want to know what you're doing in Singapore or in Beijing. And you can only do that if you've got connected educational systems. And mixed reality really does allow you to do that in a way that no other platform can, I think.
Yeah, well, I think that's a great vision. It's not necessarily a vision. We're already doing that to some extent. I mean, we've run clinical simulation across 3 continents simultaneously. And I think the ability also to be able to experience those simulation sessions using your mobile phones as content onto the content goes a long way to what you describe as that democratization process. Yeah. So I think it's wildly exciting, what we as an industry are doing, and how industry is working very closely with great innovators and great thinkers like your team at Imperial and all across the world, really. So just to close out then, 10 years from now, what's it going to look like for a student coming into education? And what's it going to look like when that student graduates, finishes all their training and they're working? What's the landscape then?
So before I answer that question, I would just kind of follow up on the point you made, that I think the only way that we get to that vision, whatever that vision is through collaborative working. And we need industry and academia and healthcare providers to work together on this. Like the innovation is going so quickly, right? We need that, and we also need we don't need a monopoly. We need a diversity. Like, we need startups to succeed. We need these kind of heterogeneous, innovative environments for this to really work. And I think that's really important. So we want, we need GigXR to succeed. And you're not paying me to say that. What's the future going to look like? Well, I'm pretty excited about the future. I think for us in practice in the UK, it's going to mean that technology is going to enhance our educational experience such that we will be able to train our people more efficiently. So I think the timeline of training is going to drop and it's going to become much more efficient. I think we're going to be able to leverage these technologies to augment the clinical portfolio of adjunct clinical specialities, so our nursing colleagues, our physio colleagues, our nurse specialists, to be able to perform more complex tasks to fill some of that gap. So I think if you can demonstrate and validate that you can train to perform a task like putting in a urinary catheter, putting in a chest drain, putting in a tube here and there, actually you empower people to do more. And I think we're going to really rely on that. I think you're going to see the more widespread use of mixed reality across the board to allow you to do that. I don't think it's necessarily going to look like it looks like today with quite expensive headsets. So the headsets the cost is all going to come down and they're going to become, I think, more freely available. And I think we're going to see a much more sophisticated pedagogy that defines the value add for these in particular circumstances. So we're very, interested, for example, on how you use these to improve the learning experience for people who are neuroatypical, and that sort of way. So I think you'll phenotype trainees into their particular learning style, and then you'll really apply those technologies to get the very best out of them. And I believe that within 10 years from now, you would, if you know, you're not going to go to many med schools and not see some form of mixed reality technology. It's going to become the standard for visualizing and experiencing and interacting with many aspects of medical training and learning. I just don't see why it wouldn't.
Now, that is a great soundbite, that last one. Well, listen, look, on behalf of everyone in our industry, on the industry side, thank you for your commitment to this medium. We think that healthcare needs people like you and your colleagues, and we look forward to driving this agenda as safely, efficiently, but as quickly as we possibly can, so that we can continue to deliver value.
Well, no, thank you. Like I said, we're all on this journey together, and we need it to succeed, right? Because actually, the benefits to our society, if it works, are quite significant, I believe. So, yeah, let's do it.
All right, James, thank you so much. I'm David King-Lassman. This is ExploreXR. Thank you for tuning in.